have now the pleasure to introduce the panelists. We will have some minutes for a panel with Ajay Rangaraj. This is the lead technical office, Advanced HIV Disease at WHO, and Nikia Forbes, National AIDS Program Manager, Bahamas. If you can stay here and we can... Thank you very much, Nikia and Ajay, for accepting be part of the panel. So the idea of the panel is to try to bring down, to the what is this of about advanced HIV disease. So maybe we can start with the WHO, with the global level, what is the situation and what is coming in.
Thanks so much, Omar. Firstly, I just want to say thank you to all the organizers for putting this wonderful event together. I think it's really fantastic to be here with so many countries in one room. I think it's a rare opportunity for us as well to interact with so many of the Caribbean nations. So truly, it's a pleasure to be here. So I think Omar already presented some of the things that I'd spoken about in the pre-workshop webinar. So I think maybe the things I wanted to cover on is sort of what's the direction in which we're going with advanced disease, what's happening in some of the other countries, and some of the other related but very important work that's happening at the global level. So I think the first thing is that we recently published an advanced HIV disease research landscape document. And this really, the goal of this is to identify, because I think there's a general understanding or belief that advanced disease is this sort of very specific, narrow region of science which exists within the HIV world. But truth be told, it actually has a fairly broadly encompassing impact in the sense that its impact is actually disproportionate to the supposed size, shall we say. So in the process of doing this research landscape, we identified that there's about 9 different focus areas, which includes cryptococcal meningitis, histoplasmosis, Kaposi sarcoma, a number of other OIs such as the PCP pneumonia. We also have CMV, toxoplasmosis, as well as, in addition to this, of course, we also have emergent diseases such as Mpox as well, which again disproportionately affects people with advanced disease. And of all of which we do have specific priorities. And some of these priorities are currently CD4 testing. The second is cryptococcal meningitis management, histo was already mentioned, severe bacterial infections, and then of course, needless to say, tuberculosis. And I'm listing these in no specific order. So I think the goal is that we're looking to develop guidelines and guidance documents in the coming year. And I think some of the key guideline questions that we're looking at, the first one of which is related to CD4. And I think for the longest time, most countries globally have been using clinical staging, or the so-called WHO clinical staging from 2006 or 7, which really allows you to decide if somebody has an advanced HIV disease or not. But we know that there's a better way to do that through CD4 testing because it tells you exactly what their CD4 cell count is. It gives you a general sense of their immune status. So this question we are trying to address in the guidelines because we would like to push forward this need for CD4 testing in that we know from previous reviews that you miss around 40% of people with advanced disease when you use clinical staging. So that's actually a very high number, and it's likely higher in some settings, in others, accounting for that confidence interval, which I think is problematic. So I think and also I think it sends a very strong market signal because many of you may have heard that there's been declines in CD4 availability or certain producers have left the market, so on and so forth. So I think this is partly because of sort of differences in interpretation of guidance. And essentially, of course, WHO always made the recommendation that viral load assessment is the preferred way to monitor somebody who is on treatment because it gives you a sense of the viral load count in somebody's bloodstream. But what it doesn't do is give you information about that person's immune system. So I think this is where the nuance is lacking in the sense that they're technically telling you slightly different things about the individual who is being treated. So And advanced disease is very much tied to the immune status, because that's what determines whether they get an OI or not. So that's obviously a point of focus. The second is related to post-discharge interventions for people who are hospitalized. So now we know from a systematic review that we did back in 2022, we know that the post-discharge mortality and readmission rate for people living with HIV is very high. So now we know that so we used a compound outcome in this systematic review where we found that approximately 32% or a third of individuals who successfully leave the hospital either die or get readmitted within a year. So this is quite really a sobering number when you really start to think about the reasons why and the fact that these are successful discharges from a hospital. So obviously, there's obviously failures with these individuals being linked back to care. Some of them never make it back to the clinic. Obviously, the hospital-based systems don't really interact with the clinics. So obviously, there are things that we can look for that can help improve those outcomes. Because if you're losing a third of people living with HIV who are going into hospital, are you really helping this group of individuals in the long term? And then the last one is related to Kaposi sarcoma. So Kaposi sarcoma, as you know, occupies a strange place in sort of oncology, and there's been a wide range of different treatments that have been used for Kaposi sarcoma over the years. And also its incidence is quite geographically determined, shall we say, to a very specific region, but it again disproportionately affects individuals in that region. So we're looking to make recommendations on a preferred regimen for Kaposi sarcoma. And of course, these systematic reviews are currently underway. We also have been doing some of the more broader global level epidemiologic work where we're looking to publish some data on the prevalence of advanced HIV disease that's available in published literature. We're also looking into the causes of hospitalization, which you saw up on the screen just recently. And we also will be publishing a sub-study which looks at the deaths and the causes of deaths. And I think you'll see, at first glance, you can really see that there's such a paucity of information, regardless of where you look for cause of deaths in people living with HIV, and then worse still if you look in advanced disease. And then, of course, maybe the other very significant thing, which we will share the link around with all of you present here, is that we've embarked on a Delphi process, which is a sort of multi-stage process of collecting opinions from experts, public, so on and so forth, on evaluating the sort of evolving terminology around AIDS and advanced HIV disease. So I think somebody earlier had mentioned about this use of the word AIDS. And, I think the whole idea is that there are some groups, excuse me, globally that believe that, particularly among the representatives of civil society organizations, that they should really take ownership of this AIDS terminology, in that advanced HIV disease is not conveying the urgency and importance of what we're trying to say when we say advanced HIV disease, while another very significant group of individuals believe that advanced HIV disease is inherently less stigmatizing, so therefore would be a preferred terminology. It's also attached to a scientific definition, shall we say, of a very specific CD4 count. So we had an initial round of the first round of the Delphi process to collect sort of a broad range to brainstorm some viewpoints, upon which a survey has now been designed. This survey is on the WHO website, and you can participate by just clicking a link to the survey and sharing your thoughts. The idea is to collect as broad a range of opinions, and that's what the first stage of a Delphi process does. So I think this has significant implications as well as to how we will communicate about AIDS/advanced HIV disease going forward. This will be reflected in policy documents, in events, in guidelines across the board. So we strongly encourage you to participate in this process because we do feel it's the right moment at which we should be talking about this. And sort of the last thing is that for the last 2 years, we've been running what's known as the TRACK series, or the technical resources for advanced HIV disease, capacity and knowledge. And the real goal has been to help capacitate healthcare workers in the field who see various complicated cases of advanced disease on a daily basis. So we've done about 8 webinars now. We have about 98 countries. I know that we do have a few Caribbean countries participating. We would like to expand because, of course, the time difference is always a problem. It's always hard to administer a global series sitting in Europe. So, to have people sitting in Japan participate at a sensible time and people on the California West Coast participate at a sensible time. It doesn't exist, is the answer. So I think this has been a conversation we've had with Omar.
Thank you very much. I think it's very interesting, this Delphi process, this survey, and I'm very interested in what the outcome will be. Maybe we might we have to do many changes, including the name of the society, International AIDS Society. But let's see what's happened. It is resonated in your comment about the small volume, or maybe the perceived small volume of advanced HIV disease and the big impact it can have in terms of mortality, but also in terms of economical resources, inequities, and a lot of effort that is needed to put on those after the patient is diagnosed with advanced HIV disease. For this reason, I wanted to ask Nikia, and we will come back to you with question and explanation, and Yamuna that is in the also connected. But I wanted to see your perception as an HIV provider, an infectious disease specialist, but also the National AIDS Program manager from a country that made a lot of strides in the HIV. What is your perception about the problem, in particular for the Caribbean, the advanced HIV disease? I think you have a mic there. Okay. So what is your view?
Thank you for that. Can everyone hear me?
Yeah, perfect.
Wonderful. So the topic of the panel is translating the science of advanced HIV into action in the Caribbean. And I love my job. I must say that I've been practicing HIV medicine from since I was a very young doctor, from since I was an intern and a junior doctor in my 20s in our hospital. And the landscape of HIV has really changed from since then. That was largely in the pre-ART period, pre-antiretroviral therapy, for all of those in the room, before we had medication. And we had wards full of patients with opportunistic infections, and this has changed largely in terms of my current service. I do head the infectious diseases clinical service in our hospital. We have a 400 to 500 bed hospital. We usually run a inpatient census of about 28 infectious diseases patients, and I'm really happy to say that most of those patients are not HIV related anymore. They're complex bacterial infections and bone and joint infections, but HIV is a particular passion of mine. And so I will say that when you hear numbers, and the New England Journal of Medicine has published a op-ed in February of 2024, and that was entitled Advanced HIV Disease, a Neglected Disease. When we hear some of these global statistics, 4 million people may be affected with advanced HIV disease. 600,000 people may die per year of advanced HIV disease. We know in the Caribbean it's also a problem. 1/3 of patients, according to the WHO in 2021, presented with advanced disease. This is not different in my country, the Bahamas. We have a population size of about 400 people. We have a generalized and concentrated epidemic as it relates to HIV. The general population, the prevalence is about 1%, and we have a concentrated epidemic, for example, in MSM, that can be around 19%. And so what are we seeing in 2019 with the available CD4 count data? We had about 28% of the patients presented with advanced disease. So I can tell you that in the Caribbean context. Then we know that there is some limited data as it relates to presentations with advanced disease and what some of these infections and presentations may be. We did a retrospective study in Cornwall Regional Hospital when I was a consultant there. That's in Western Jamaica. It has a very large prevalence of HIV in Jamaica. And we found that of the hospitalized patients, which you know is a skewed population, about 79% of those patients presented with advanced disease. And the CD4 count the mean was 95, terribly low. if we think about the definition being a CD4 count below 200. We also had WHO stage 3 and 4 staging, and the majority of patients had WHO stage 4 staging. About 75% of them did, and this is what we found. The majority of the patients had PCP. For those of you who are not healthcare workers, I have my colleague here from civil society, and she says the acronym is Dr. Forbes. So pneumocystis carinii or Jirovecii, pneumonia, a very, very bad pneumonia for people who have immunocompromised systems. That accounted for about, let's say, just under 49% of presentations. This was followed by CNS toxoplasmosis, very bad brain infection. Interestingly, that was then followed by renal disease, HIV-associated renal disease. It's a big problem on my service. And then we had some cryptococcal meningitis. I will say now that study was probably a little bit skewed because there's a large chest hospital that treats most of the TB infections in Jamaica, and so maybe we don't really have the benefit of admitting those patients. Now, I'll tell you anecdotally on my hospital service now that we still have largely PCP presentations and CNS toxo presentations. We have a huge burden of renal disease and renal failures. They need dialysis catheters. Renal transplants is very hard to get. In most countries, it's even worse in developing countries. And so then you're going to have this problem with bacterial superinfections, which we talked about in the pre-meeting workshop and again today, when it relates to these catheter infections and these bad bugs, as we call them, that are extremely hard to treat. And then we've got some cryptococcal meningitis. So we have made some progress when we look at the decline in AIDS deaths. In the Bahamas, in the past 10 years, and you will see this in the UNAIDS country report, the Bahamas, we've seen a 48% decline in AIDS deaths, a 58% decline in new HIV infections. But it's interesting, and I agree, that when you read the New England Journal article, it states, yes, we've made significant declines in new infections and even AIDS deaths, but we still have this proportion of patients that are presenting with advanced disease. And so we've got to do something about that. And maybe this sort of got overlooked a little bit, to be totally honest. And I'm going to tell you why. So I did really enjoy the webinar, and the science is good and hard. I'm going to take a moment now to try and translate that down into where the rubber meets the road in the Caribbean. So I'm going to start with the first talk, which was, first of all, the overall landscape in diagnosing advanced disease. So clinical staging is good. There is CD4 counts. Now, I'm going to take us back. Well, I've been the program director in the Bahamas. I've been honored to do that job for about a dozen years now. And so when we took the global shift for 90-90-90 and 95-95-95, I do remember the donor landscape, and donors drive a lot of things in developing countries. And the focus now on viral loads and CD4 count, oh, you only need to do that once a year. But the ID doctors among us said, no, but we need this for staging. We need this because it provides an important intervention. When you see the CD4 cutoff, that tells you you've got to prevent infections primarily. It's called primary prophylaxis to prevent PCP. You can give Bactrim, that also prevents toxo. Do you need to give an antibiotic to prevent other pneumonias? This can help significantly. It even can prevent disseminated MAC, depending on some things. So we always knew that you needed the CD4 count, and I remember telling the donors that. Now, in the Bahamas, we're lucky. We're not so donor dependent. We actually have an almost 100% domestically funded program, and I think we're doing tremendously well. When we look at our cascade numbers, we're at 93, 75, and 92%, but we still have room to go. We need CD4 counts, donors, the donor funds transitioning has sort of impacted this in many countries, and it can help from the beginning to start the patients on primary prophylaxis and then secondary prophylaxis, but the horse is already out of the gate when you're doing secondary prophylaxis. The patient has already presented with the infection. The other thing is points of care, CD4 diagnostics. It's very hard to find those in the Caribbean, maybe in other countries as well. So a real game changer is going to be those point-of-care CD4 tests. Omar, you and I spoke about that in March, and how that can impact the science in a very little time, where you can now implement this prophylaxis in the clinic. In the Bahamas, we all have grades of staff. When we have a specialty service, we've made templates, SOP forms, so that you can know, do a cryptococcal antigen, take a toxo IgG titer. I'm sorry, I'm speaking medical jargon. Do these tests and screen. Do TB screening, for example. We've implemented that in our points of care clinical forms. I think we're running out of time. For TB, we need science to drive the decision. Not all countries have a high TB epidemic like Africa, where a lot of those studies are. Some of the countries are very low TB incidence. In the Bahamas, we have an intermediate TB incidence. We do have migrants. We have about 11 to maybe 13 cases per 100,000. In 2023, we had 27 cases. About a third of those were HIV co-infected. The year before, we had 4 TB deaths. 75% of those 3 cases were indeed HIV co-infected. But we have implemented in our clinic screening using cough, night sweats, fever, hemoptysis, weight loss, for example, and TB screening, whether that's the skin test or otherwise, to determine if, and we have made a one-stop shop where we can start the patient on isoniazid and have the TB screening in clinic. What we need is shorter regimens. It's good to know that there are some of these regimens that don't interact, but shorter regimens will also be helpful. They're not really widely available in some places. Cryptococcal meningitis, liposomal amphotericin B. Again, that's very expensive, hard to get, but as we're seeing from the workshop panel, a shorter course, single doses, combination therapy can be very, very helpful. I'm going to go on now to histoplasmosis. When I was a younger doctor, I had a senior doctor, and there was something he would say when we went to do our bedside rounds, and that was, the eye cannot see what the brain doesn't know in medicine. And if you don't know about histo, you can easily confuse that with TB. Not all patients are going to have disseminated disease. And so we do need to raise awareness. We need to look at, is there available information? Is there a knowledge gap? How easy is it to get this information? And it's really hard to diagnose histo in the traditional methods. It's very hard to get a bronchoscopy or bronchoalveolar lavage and bone marrow. And so again, the rapid test, where applied as needed for appropriately, will help a lot with histodiagnosis, because some of these patients will be on TB treatment for a long time, and then you'll see they're not getting better. Then lastly, I would like to talk about cause of death data and the need to formalize that. I really enjoyed that presentation in the pre-workshop presentations. I think that there's a big opportunity there for idea sharing on the flows. I myself looked at the 61 cases of AIDS that we had in the AIDS deaths last year, and it was a lot of PCP, cryptococcal meningitis, and encephalitis. But the number one thing I would say is all of these things are largely preventable. And so even one case is too much. And I think that there is a huge opportunity for us to look at our country's specific challenges and the opportunities as we move ahead, and as it relates to how we translate this into science. There will be more things that I'm very encouraged to see, that community engagement, how to monitor and evaluate, SOPs, information exchange, knowledge sharing. There are opportunities for all of that, and of course we have set the stage, and there is a way forward, and I look forward to research to drive the decision and a call to action. And that's it from me. Thank you.
Oh, thank you very much. An applause. Because it's really a pleasure to continue listening. Yes, it's very comprehensive and very clear what the importance in the country level also, and also to figure out how to put science, technical knowledge, and really public health vision to reduce deaths. Ajay, talking about that is the health system is in the middle. So how, in terms of talking about integration and where to do the test, when to do the test, how do you see the advanced HIV disease fitting there from late diagnosis until death,
Yep, thanks. And I think what your comments, I think, are very insightful into understanding some of the challenges and the profile of cases that you see. And I think the main thing about advanced disease is that if the health system has any kind of weakness, advanced disease will suddenly rise up. It's almost as if it's an indicator of health system strength, essentially, because essentially if your inpatient and outpatient care centers are communicating well, then you have a clear transition, you have good transitions of care. But the problem is with advanced disease, you have lots of individuals disengaging from care because maybe they start ART, they start to feel better, and they stop taking ART. And only when they start to feel unwell again, they come back into care. So now again, the burden of that rests with potentially hospital-based care and outpatient to some extent. But predominantly, these individuals will come back quite unwell, and they will go straight into a hospital for ward-based care or ICU-based care. And some of them, obviously, I think we saw very sobering numbers in terms of mortality, but those individuals who are being discharged, often programs the hospital doesn't have, shall we say, a protocol in place on what do we do when we're discharging people living with HIV, what are the key tenets that are required to link them back to care. Maybe they need a home visit, because the things that we don't talk about are, for example, functional status. So if you have ever seen an individual who has recovered from cryptococcal meningitis, these individuals have very poor functional status often, and it takes several weeks to months for them to come back to normal. So these individuals may not be able to take themselves to a care center upon discharge. So whose responsibility is that? Programs should be taking the initiative to potentially organize for social worker visits or something to that effect. So that's sort of what prompted us as well to look at these post-discharge interventions. And I think one of the points that you made regarding what the eye cannot see if the mind doesn't know, and another instruction you're given as a clinician is that when you hear hooves, think of horses, not zebras. So this is actually a deadly combination if you have both, because it means you're going to miss every single case of histoplasmosis, thinking it's TB because you just think it's more common. So I think to that point, I think this training of healthcare workers is a really important active programmatic activity that has to be sustained over the long term. And also, speaking of the 95s, the 95s are excellent at telling you who is doing well, but it does not give you a sense of who is not doing well. We actually have no idea. If you just look at the 95s, you have no idea. What of those people who don't have viral suppression, what's happening to them? You don't know. So I think this is why it's so important to bring advanced disease more to the forefront as a key part of system like HIV programming. And lastly, in terms of balancing out this, I think, as you know, we recommend a package of care for advanced HIV disease. And what's important to know is that all of those individual tests that you can do for various opportunistic infections and CD4 can be offered at point of care. This is true for cryptococcal antigen. There's even a semi-quantitative CRAG test available. You have the histoplasma tests. You also have a lateral flow assay test for CD4. And then, of course, the LAM, or the lipoarabinomannan test for TB, which is a urine-based test. All of these can be done at point of care, and of course, GeneXpert or any other TB molecular test that's being used. All of these are either point of care or near point of care. So these can really be shifted out of facilities if that's where they're sitting, to help address these gaps in care, as well as also create a better sense of the continuum of care for people living with HIV. So, I just think those
Thank
things
you.
reflect.